Okay, our next speaker is by Dr. Ahluwalia. He's the Executive Director for the Center for Health Equity at the University of Minnesota. His talk today is entitled The Center for Health Equity, Leveraging and Partnering. Dr. Ahluwalia.
Well, thank you. Thank you, everyone, for the invitation. As you heard a little earlier, too much feedback? Or? Oh, yeah, I was going to do it. Yeah. There we go. So it's coming back home a little bit. I used to be in Atlanta, actually. From 1992 to 97, I was on faculty at Emory, and my office was actually just down the street, on Butler Street at Grady Hospital, where I saw patients and started my research career. And then you heard earlier, I know Mark Becker from other circles, and your dean, Michael Erickson, was a very good friend in the early 90s and a neighbor, actually. We just lived a couple blocks away from each other. So I direct, let me just, that's, by the way, Minneapolis, 6 months of the year. And the other 6 months of the year, is it possible to turn the lights a little dimmer on the slides, maybe? If you can. I don't know if you can do that. But anyway, so I just wanted to highlight the minus 33 degree wind chill factor. Minus 11 was the temperature. But the good news is it warmed up as the day went on to minus 5. And I went to med school at Tulane and lived here in Atlanta, and I've only done one thing, which is head north through Kansas City. Turns out you can't get any colder. Even where Anna is in Michigan, it's relatively warm compared to Minneapolis. So I'll just tell you just a teeny bit about myself. I sort of have 3 roles at Minnesota. One is I direct the Center for Health Equity, which is the same thing that Anna directs at Michigan, and Michael Erickson and Rodney direct here. Here it's a P20. We have a P60. They're essentially the same thing. They're funded by an institute called the National Institute of Minority Health and Health Disparities, and you heard Dr. Satcher refer to that. Just 2 years ago, it was a center. And to get elevated to institute status at NIH is a big deal. It actually takes congressional approval. And the NIHD is directed by John Ruffin, who's been directing that entity in one form or the other over the last 20 years. And as I serve on council at his institute, I was with him last week, and we were actually exchanging emails this morning. He sends, I pressed a button. He sends his regards to everyone. So that's a very important institute at NIH. We also have, as do 60 other institutions in the country, another NIH grant called Clinical and Translational Sciences Award. They tend to be at health sciences centers. It's a very big grant, actually. In Minnesota, ours happens to be about $55 million over 5 years. It's all federal money. And there I direct research, training, and career development, and I'll tell you about something else in a bit about that. And then finally, I do nicotine and tobacco research in African Americans. That's sort of my area of research, and I've been doing that for 20 years. And that started, of course, here at Grady Hospital. So I moved in 2005 to Minnesota to establish an Office of Clinical Research, something that I actually am only involved in a smaller way. But in 2009, about 3 years ago, now I guess 4 years ago, we received the P60 award and established our center called the Center for Health Equity. And then I'll tell you a little bit later how we've just recently integrated that into this larger monster called the Clinical and Translational Sciences Institute. So our vision for our center is to become a national leader in health disparities and minority health research, serving as a resource for research training, community engagement, and research. And our mission, probably similar to yours, is working to create an informed, empowered, and activated community that collaborates with researchers and practitioners to improve the health of their populations with the goal of health equity. So this is our team, again on a bright sunny day. They're in Minnesota. We have them occasionally. And so this talk is going to be quite different than the previous 2 speakers, Dick Warnicki and Anna. And hopefully the 3 different talks will gel together and give you a different perspective of the different aspects of these centers. Mine is going to be a bit more sort of what we're doing kind of thing and best practices, or at least we think they're best practices and things you can do with it. So this is just our little org chart here at the Center for Health Equity. And we are now housed, as I mentioned, in this big Center for Clinical and Translational Sciences Institute. We have a Community Advisory Council. We have an External Advisory Board comprised of some very nice, smart people. Mona Faoud at Alabama, Sherman Janes at Duke, Lovell Jones at MD Anderson, Spiro Manson in Colorado, Leslie Perez Estable at UCSF, and Steve Thomas at Maryland. And actually, Steve used to be at Emory back in the early 90s as well. We have an Internal Advisory Board, and then we've got an Executive Committee. And we've got 3 cores: Research, Training, Education, a Research Core, and a Community Engagement Core. Our 4 aims are to promote health disparities and minority health research at the university and the metro area, the Twin Cities as they're called, enhance community partnerships to improve health status of African American and immigrant populations. That was sort of our target population. Recruit, train, and mentor research leaders from underrepresented populations to conduct work in minority health. And the 4th aim was to integrate universities' minority health and health disparities programs and resources into a seamless infrastructure. For those that don't know, University of Minnesota is a very large institution. For undergrads and grad students, et cetera, we have almost 50,000 students. And there's a campus in St. Paul, there's a campus on the East Bank, and there's a campus on the West Bank separated by the Mississippi River. So we believe that achieving health equity requires partnering and leveraging, and that's sort of the theme of the talk, and I think the theme of our center. The benefits of partnerships are, I think, no mystery to the people in the audience. This is preaching a bit to the choir, but the ability to exchange knowledge and ideas, to engage community support or concern for these issues that are of relevance, to have collective action, to improve trust and communication among organizations and people, which I left Atlanta in '97, so I don't know what it's like now. But when I arrived in Minnesota in 2005, an area of Minneapolis that I'll show you on a map called North Minneapolis basically completely distrusted the university. I mean, essentially hated the university, thought everything they did was wrong, and basically that they were experimenters, that they were always coming inside their community and wanting to basically experiment on their people. And that's sort of what I had come to, which was very different than it was, believe it or not, in Kansas City, where the trust was very strong. But also mobilizing diverse talents, resources, and strategies. So our center, as I mentioned, has these 4 cores, and just starting with the administrative core, obviously a key part of the administrative core of any center is communications, and so maybe it's based on my age, which I just turned 50 this year, is that I still believe in having things in paper. I get the New York Times. I don't get the digital New York Times. So I still like to have hands-on materials, and of course this is also done electronically as well. So we have a brochure, and some of you might recognize former Congressman Kwesi Mufume here from Maryland. He was our speaker last year. We, of course, also have a newsletter, which people actually read, and we can track how many people get it and subscribe to it by the listserv. And it's something that we take seriously. We try to keep it simple and short. It's only 4 pages long with lots of pictures so people can be entertained and not have to read as much, but get the story point pretty quickly. We have a website, which one of you at lunch was kind enough to compliment us on our website. I actually think it needs more work, but this is it, and this is hot off the press. We have Nancy Adler coming from UCSF on April 3rd as our speaker, and then actually in May, we have someone who was at Michigan, now at GW, Paula Lance, is our speaker in May. So this is a monthly program that I'll tell you about. Well, I'm telling you about it now, actually. Here it is. These are research rounds, we call them, Center for Health Equity research rounds, and it's really just a gamut of topics from primary care to smoking cessation in American Indians to Ichiro Kawachi talking about income inequality and the Gini Index and things of that nature. Robert Wright, who's an environmental person, environmental pediatrician, actually, he's also an epidemiologist. It's really quite well attended, and what it's done is it's raised the profile of our activities on the university campus. So if anyone's been to, how many people have been to Minnesota? Oh, wow. Wow, okay. So that's interesting. That was a surprise. So I'm not sure what you're doing there, but maybe you flew in there. Maybe you were flying from the East Coast to the West Coast, and it was a Northwest and now a Delta hub. But of course, you're a Delta hub here, so you don't need to stop through Minneapolis. But Minnesota was largely a very large Scandinavian Germanic population. Almost everyone's Lutheran except for me and 2 other people. And recently, there's been a wave of it's a big refugee resettlement program through USAID. So we have one of the largest Somali populations in the country, a very large Hmong population, and of course a growing Latino population, both urban and rural. But it's largely a white state, and as a result, the university itself, just by history, is largely white, at the leadership level, unfortunately, still quite male-dominated. So a lot of what our center had to do was literally just begin to change the culture and so on and so forth. It's very different than living in Atlanta, or even when I lived in Atlanta in the early 90s, when you're just surrounded by diversity. For example, when we go out to the theater, my wife and I always sort of bemoan, it just seems like there's one color in the audience, and it's not multicolored. And so as a result, just doing the things that we do is often to begin to change the culture and get that transformational shift going on at the institution. And it's working. In community engagement, we've spent a lot of time just breaking bread. I'm a food person, but just sort of having meals with people from the community, providing lunches for events, and trying to just regain or establish trust with people in the community. The one thing that our previous president did is he invested some funds in the community. So just for those that have been to Minneapolis or not, this is the mighty Mississippi running through here, which people often think separates St. Paul and Minneapolis. Well, it turns out it doesn't do that at all. What it does is it separates the East Bank and the West Bank of Minneapolis. The university is right here, and that's the East Bank campus. And on the West Bank is the law school and the new children's hospital and things of that nature. And right over here is a section of Minneapolis called North Minneapolis. And just to give you an idea of North Minneapolis, the infant mortality rate, or the life expectancy of people living in North Minneapolis compared to some of the western suburbs like Wayzata or Edina or Plymouth, for life expectancy, the difference can be 15 to 17 years life expectancy. So that's the kind of numbers that are quoted when we compare differences, for example, not to do this, but between Bangladesh and the United States. So it's quite dramatic. Infant mortality rates are very high in North Minneapolis. Well, there was a building that was boarded up over here and closed for many years. And right across the street is the Minneapolis Urban League. And then across the street from there is the largest community health center in Minnesota called North Point. But President Brunix, actually right at the beginning of the fiscal crisis, when we got these huge budget cuts, as everyone did, it was a state institution, decided to spend the $5 million to renovate this building. It's a 20,000 square foot building, and house programs that made sense so that we were actually physically located in North Minneapolis. So this is right in the heart of Minneapolis. And our center has about 1,000 square feet of space in here. There's an actual nutrition kitchen where you can have cooking demonstrations. There's a computer lab in there. There's conference rooms. There's a big conference room here that's shared with the community, and there's staff as well from the law school and social work and otherwise. We have two formal partnerships in our center as per the guidelines from the grant. One is with Stair Step Foundation, which is an organization of 21 African American churches. And our project there is the implementation of a program called Body and Soul, which interestingly enough was a program that was developed here in Atlanta by a close friend of mine named Ken Resnickow, who used to be at Emory School of Public Health, now at Michigan. And that program has been around for about 10, 15 years. And that program was about increasing the consumption of fruit and vegetables in African Americans. And so this is now a dissemination project. And as much as we can, we try to direct actual dollars to community organizations. So Stair Step Foundation actually gets $25,000 a year, every year from our center grant for 5 years. That same amount of money also goes to another organization called WellShare International, which is a Minnesota-based international nonprofit that does work locally and globally to improve the health specifically of women, children, and their communities. And Diana Dubois is the president of that organization. And in this particular project, they're focusing on smoking cessation and prevention strategies for smoking in Somali members living in the Twin Cities and Minneapolis specifically. Another program that we started actually right from the get-go, so it's been going on for about 4 years, and it happens 6 times a year, and we do provide lunch, is folks in the community, whether it's in St. Paul, North Minneapolis, or Minneapolis, will identify topics that are important to them or their community. And they then approach us with that particular topic. Let's say it's depression, or it's domestic violence. I'm naming topics that we've covered. Or diabetes. And then we provide sort of expertise from the academic side to actually go physically out to the community and have a community dialogue about that particular topic. So it's facilitated by a community member, and then we have the academic presenter as well. Here's some other topics. Uncooking childhood obesity, barriers to mental health care, because this is often a stigma in certain immigrant communities. Understanding non-daily smoking, that's actually my postdoctoral fellow, and even things like immigrants and healthcare law. We also go beyond what we said in the grant. These centers are not contracts, they're grants. So to some extent, you don't exactly have to do what you said you were going to do, and you clearly can do more than what you said you were going to do. And that's not something people often go to the mic and say, but it's something that we've been doing for 20 years and quite successfully. So we don't have any necessarily language in our grant to work with LGBT communities, but we feel it's a very important component of the health disparities and health equity dialogue. So we partnered with Rainbow Health Initiative, which is the largest organization related to healthcare in this population in Minnesota, and to advance the health and wellness of this community. We've been partnering with them on 2 LGBT health panels that we've done with medical students on campus that have been hugely successful. You would be surprised, or maybe not, to know that most medical schools do a very limited amount of teaching and education in the area of working with patients and people from LGBT communities. Then the other thing is that we really, one of our staff members, or all of us really, try to be present everywhere possible that we can so that we're seen and visible. So whether it's health collaboratives, health equity working committee, state panels, we really try to go out to those meetings and participate very actively with not necessarily any net gain back to us, other than we're building friends and we're getting more trust, which is really critically important to build a solid foundation. The research, training, and education piece, I would argue, is our strongest piece by far. And I think it goes back to maybe what Dr. Satcher and maybe even what Mark Becker were talking about, which is sort of really investing in the future. And so one theme that we generally have is that we want to increase those from underrepresented populations to lead programs and conduct research. So they're essentially our future leaders. And then specifically to increase research capacity in communities as well as academia. So usually most people tend to focus on the academia side, but I'll tell you about a program that we're doing in the community as well. That program is called the Community Research Institute. We did it for the first time last fall, and it's on deck again for this fall. It's a 6-week research institute for community leaders. It's not every day by far. It meets 1 day a week and for 6 weeks. And we had 28 community members from 11 organizations participate in it. And partly to offset expenses, which there weren't really any expenses, we gave each participant $1,000 from the grant. Again, I think there was a big piece of goodwill here, and as well as sort of the idea of the partnership. And the topics that were covered were things like IRB, believe it or not, a 2-hour seminar lecture about study design, the idea of clinical trials, what does that mean, and cohort studies and survey design. Talking also about responsible conduct for research. How do you build your own survey using REDCap? I'm sure some of you know the package called REDCap. It's used as a wonderful tool to do data entry and to conduct surveys, web-based surveys, and things of that nature. Phenomenal success, actually. The goodwill was fantastic, and the knowledge both sides was gained was quite a bit. I guess I listed the objectives right here. So skills in research methods, skill building real-world project, understanding university resources for designing and implementing research projects, and then to eventually collaborate with a consultant from the university. I will point out, because I don't have a slide on this, we have numerous pilot programs with quite a bit of money. So we're going to issue an RFA for $400,000 from our CTSI and our center for what are called community academic partnerships. The requirement's very simple. There has to be a PI from the academia, University of Minnesota in this case, and there has to be a PI from the community. So you cannot do a grant if you don't have a community partner that has the same level of PI-ship that you do in academia. And that program's been going on for 4 years. And I have to say that often when there are pilot programs, you really want to know, well, what does it lead to? So it turns out that a number of our pilot projects have led to actual NIH funding. We've had an R01, an R03, an R21, and an R34 funded directly from pilot projects that came out of this program over the last 4 years. Something that we did about 2.5 years ago, we haven't repeated, but we are actually decided last week we are going to do it this summer. We did something called the High School Summer Research Academy. I woke up one morning in February after I had hired a new staff member and said, we really need to do something more with high schoolers from North Minneapolis. So this is a very diverse group of students, obviously, from very interesting backgrounds with lots of energy and passion. And they basically attended full-time for 2 weeks every day for 10 days a Research Academy 101 for high schoolers. It was one of the most fun things we ever did. And once again, we paid them. We paid them to participate in this academy. So essentially it was a stipend. So they got $10 an hour, which came to $800 per high school student. So we gave $20,000 in stipends to these students. I think, and we actually we evaluated what we did. And it was really tricky to evaluate such a short program, but we actually had measurable increases in awareness of research and the language and dialogue about research and their knowledge and confidence in research techniques. And our idea is that it's partly a college readiness component to their work efforts. We would love to see all 21 people obviously go to college and subsequently go to graduate school or medical school or schools of public health. Clearly, we need to track these folks over time. We have a program for undergraduates out of the center. We've had 3 cohorts, 9 in 2010, 8 in 2011, and 10 in 2012, that are from underrepresented populations. This is another wonderful program. They have a paid summer research program where they do research. They're paired with a mentor, like they may work with me or colleagues like myself at Minnesota. And there's a summer seminar series. It's not just giving them money. We meet with them once a week on Wednesdays for 2 hours. They get a textbook called Designing Clinical Research. They get peer-to-peer mentoring, networking events. They present a poster at an annual big Research Day symposium on campus. And they're also actually given the opportunity to present nationally as well, and we pay their expenses to present nationally. We have another program for advanced research program, we call it. These are for pre-doctoral students, public health, medicine, dentistry, nursing, and pharmacy students. And we have 10 students every year, and we've been doing this for 3 years as well, and essentially the same benefits there. Something that started last year is we don't do a lot with our medical students, even though I'm in the medical school, and that's where my faculty appointment is. And we had written that as actually part of our grant. And there was a great opportunity that came along. The medical students had been doing this program called Urban Health, or something along that line, for a couple of years. What they would do is, right before the first day of the first year of medical school started, there was a grassroots effort from med students to actually have you could come if you wanted to, 2.5-day program on urban health. In the 4th year, they approached us, our center, about sort of taking the program a bit more uptown and investing some money in it. So their budget went from $500, where they begged $500 from the dean, to we gave them actually up to $10,000 for the summer to put together a rather robust program. So we did it, and we had 51 students this past summer enroll in that Introduction to Urban Health Equity. It was fantastic. We did something called it's a poverty simulation program. You can actually buy this kit, believe it or not, and the students all went through the simulation effort. We had a panel on Hmong health, Karen health, LGBT panel. We had a journal club. They did a volunteer experience, and we sort of had a round-robin tables on immigrant and refugee health. The students loved it, so much so that just a couple of months ago, they formed a club in the med school called Advancing Urban Health Equity that has now sort of become in partnership with our center. So we're working now very closely with the med students, and we're thrilled about that because you can see that the med student class is still rather homogeneous. I was trying to think of that word, actually. Couldn't remember. Yeah, thank you. We're working on heterogeneity. Yeah, we've got some heterogeneity going on here. Okay, I'm trying to find it here. Okay, there's some. We're working on it. We're still working on it. It's a work in progress. Our research core might be our smallest core, but there we have a monthly seminar series called Research Works in Progress, where people on campus not affiliated with the center can present their works in progress and get critical feedback, where senior scientists are in the audience and give them feedback on statistics, methodology, or whatever the case may be. We have a quarterly luncheon series called Building Bridges, and that's a term that I had come up with years ago because the Health Sciences Center is on one side of a street called Washington Avenue, and the main university is on the other side, and the two, shall not meet. No one ever talks to anyone. Usually meets someone on a plane in a different city, and they're in the sociology department or another part of the medical school. So the idea was that we want to build partnerships between our center and entities on campus. So we've had building bridges with the Humphrey School of Public Affairs. We're doing one with the anthropology department, the psychology department. We've done with sociology and things of that nature. We also do something else which is rather interesting. I was talking about it last night a little bit at dinner, and it's something I've been doing for almost 15 years now, which is that we actually provide funds for external grant review. So let's say you wanted to put a grant in for the cutoff is $100,000. So if you were putting a grant in for $100,000 or more, and you were ready to submit it or going to submit it to a foundation or NIH, before you submit it, we would actually supply $500 for you to get that read by someone externally. So what happens is that this is a trick I learned actually in the late 90s from my friend Ken Resnick, who was at Emory, which is that, especially nowadays, for those that know NIH changed their rules about 5 years ago. You only get 2 chances at an NIH grant. It used to be 3. And NIH argued that, don't worry about it. It won't decrease your chances of getting success. In fact, it'll increase your chances of getting success because we'll actually fund more people on the first round. So I'm still trying to work that out in my mind, how that actually pans out. The problem with it is they changed that rule just as the fiscal situation, basically NIH's budget in either real dollars or inflation-adjusted dollars, especially inflation, has gone down quite dramatically. So basically, it's not true. Having 2 tries has not helped at all. So we believe that adding in a paid review, essentially rebuilding that third review back. And we do it quite extensively, and even senior people like myself I actually pay other people to read my grants. And so anytime we put an R01 in, I actually have 3 external people read it, and usually from different backgrounds. So most recently, one from MD Anderson, one from actually Dick Warnicki's shop, a close colleague of his and friend of mine, and then Ken Resnick reads it. And then we get the feedback in, we incorporate it, we submit it. There's no question it helps, because basically you've just improved your grant dramatically before it's getting peer reviewed at NIH. So we're using funds from the center that if anyone does health disparities, minority health research, they will actually contribute part of it, $500 for at least 1 review. We also support the research projects. Every center has research projects. I'll just point out Project STARS, which is a very interesting project. It's partnered with North Point, that clinic that I mentioned across the street from that University of Minnesota building in North Minneapolis, to carry out a study with community health workers, so they have CHWs at North Point, to engage parents who smoke in the house. So the criteria for being in the study is you have to have kids and you have to smoke in the house. This is not something we want. This is something they do. That gets them in the study. And then it's basically a randomized trial. They're randomized to sort of some counseling and some usual care, which is actually not bad. And the intervention group is actually getting what we call biomarker feedback. So we collect urine from the kids, which can be as young as 1 year old. You can actually collect urine from 1 year olds. You just use a soaking pad. And you collect the urine, and then we send it to the lab at University of Minnesota, Steve Heck's lab, and we analyze it for a carcinogen called NNAL. NNAL is a tobacco-specific carcinogen and actually happens to be probably one of the most potent carcinogens on Earth. It's the kind of thing if you put it on the back of a rat, a few minutes later the rat is just sort of keeling over, and that's probably exaggerated a bit, but dies of cancer rather quickly. It's really a very horrible carcinogen, and it is very real, and it's only found in tobacco. So Steve Hecht a couple years ago showed, no surprise maybe, that babies 1 year old living in homes of smokers 99.9% of the time had NNL in their urine. So imagine that. 1 year olds basically are on the road to cancer because they had a carcinogen, a very potent carcinogen in their urine. So we said, let's take that sort of basic science finding and let's translate that into sort of behavioral intervention research. So we take the finding, it takes a week to analyze the urine, and it comes back positive, which we know it's going to, and we go back out to the homes with the community health workers, and we provide that biomarker feedback for behavior change. This kind of work has been going on for about 15 years on using X-rays, CT scans, carbon monoxide machines where you blow. Basically, it doesn't work. We just felt like maybe where you were doing a biomarker not on the smoker, the adult, but on the child as the vehicle for the behavior change, that it might result in something different. Now, the main outcome variable is not actually for the parent to quit smoking. We actually just want them to take their cigarettes outside the house. We give them materials and encourage them to quit smoking. The main outcome variable, though, is that they take it outside the house. And we have many ways of sort of trying to verify this. So one is we recheck the kid's urine 6 months later and hope for it to be clean. NNAL has a half-life of 15 days. It's a long half-life. Second thing we do is you can actually hang like a nicotine badge, believe it or not. It was developed at UC Berkeley. You hang it up in the house, and it just collects ambient air nicotine, and then you just send it to the lab at UC Berkeley and analyze it. That's the second way we sort of verify things. The third way is we use the standard self-report, which has its own issues, but we ask for self-report on whether they're smoking inside the house or not. And let's see, anything else we do? Oh, those are the main things. And this project is just finishing up 6 months, and analysis will be going on later this year. Now, I mentioned this huge grant that the university has, $55 million over 5 years. So this grant has some huge cores in it. One is called Clinical and Translational Research Services, which is a lab where you can do inpatient studies. It has a recruitment core. There's biomedical informatics. There's education, training, and career development, which I direct. And there's another one called the Office of Community Engagement and Health, sort of special. It's called populations. It's a bit confusing. But in this arm, there's a piece called Health Disparities in Special Populations. And typical of most academic institutions, there's a lot of redundancy and a touch of politics involved and turf and so on and so forth. But when our Center for Health Equity moved into this CTSI over the last 6 months, our Center of Health Equity has replaced, has become this unit, besides being its own center. And it's really been great because NIH and the Center for Health Equity, as you guys know who have this grant here, they no longer provide pilot funds. When this program used to exist in the 90s, there were pilot funds available where your center, the one that Michael Erickson runs, you could actually give money away for people to do research. That's no longer allowed, actually, even if you have extra money. And so we can bring our infrastructure to the CTSI, and the CTSI has pilot funds available, as I mentioned, $400,000 a year. So our center will now direct those dollars. One of the things that our CTSI is supposed to do is to try to make a difference, like many of these big grants are supposed to do. And one of the challenges about work in the community is, what is the community? Who is the community? Is the community North Minneapolis? Is the community Latinos? Is the community Asians? Is the community the Hmong, the refugees? Who is the community? And if you're going to work with the community, are you really going to make a difference? Or are we just really not making any progress? And we think we are. So one of the challenges is, how can you potentially work with a community that's narrow, small, and potentially you can measure things more carefully over time. So serendipity has it that our center moves into the Institute. The Institute really needs a focus. And last year, the city of Minneapolis got awarded a huge grant. The city did, not the university. And became and established something called the Northside Achievement Zone. So most of you have probably heard of the Harlem Achievement Zone, I'm sure. So this is a federal program, and Sandra Samuels, who's the CEO of the Northside Achievement Zone, secured the $10 million grant to work and establish a 501c3 nonprofit that is building a culture of achievement so that Northside, and Northside means North Minneapolis, by the way. Remember that area I showed you? Children graduate ready for college. That's their main goal. And how they approach that is very multidisciplinary. Families and children move through a cradle-to-career pipeline through 3 pillars: family engagement and opportunity alignment, education pipeline, and the whole family wraparound support. So this is the zone, so to speak. Here's the university again. Here's North Minneapolis. And the zone is right there. It's bordered by Penn, West Broadway, 3rd Street, and 35th Avenue. So a very circumscribed area. Big, but yet not too big. I mean, you can walk it. Not 6 months out of the year, but the other 6 months you can walk it in this direction and that. The city is much larger, of course. Just to give you an idea of sort of place matters, that expression, place matters. This is North Minneapolis, right to about here. There's a section area called Bryn Mawr, which is a transition neighborhood. And right here are these famous urban lakes of Minneapolis. This is the state of 10,000 lakes. So it turns out there are about 900 lakes. I still can't believe there are 900, literally just in the metro area. But there's some big ones called Lake Calhoun, Lake of the Isles, and Lake Harriet. And the homes in this area, even north of the lake, in an area called Kenwood, range from $1.5 to $6 million, right here. And you just look how close that is. So it's very real that place matters, by the way. It's very real. So Minnesota, as some of you know, is one of the healthiest states in the country in terms of when you use demographic means. So it has longest life expectancy, least number of people smoking except for Utah, et cetera, et cetera. But if you delve a little further, the data gets very scary. So it turns out Minnesota actually has the healthiest and all that, but some of the worst health disparities in the country. Because remember what a disparity is. A disparity is a difference. And so let's say Georgia may have some issues about health and obesity and so on and so forth. But the thing is, it's a tighter range and the disparity isn't as great. So in Minnesota, if you're white, especially white female, your life expectancy is approaching 84, 85. I mean, the country's is 82 for white women, but there it's probably 85. And if you're an African-American male, life expectancy in North Minneapolis might be 50, 54. But if you're a female African-American, it might be, let's say, 60, 62. You're still looking at a 20-year life expectancy. So the disparities in Minnesota are really egregious. They're quite horrible. And I think people are just becoming more sensitive to looking at not just state-level data, but sort of looking a little deeper and more granularity to get a sense of that. So as I mentioned, it's impacted by crime, violence, poverty. 15,000 people live within NAS. It's diverse. It's 47% African-American, 20% white, 18% Asian, 8% Hispanic, and 7% multiracial American Indian or other ethnic groups. It's estimated to be home to more than 5,600 kids. And as I mentioned, the educational disparities are just really quite bad and some of the worst in the nation. So they're working in a very narrow area here, and they're scaling up over time. So they've started with 200 families. They're going up to 300 families this year. And at their peak, they're going to hit 1,200 families that they're going to be working with. And the key component to this whole program is something called the navigator. So navigators are assigned 30 families per navigator. And they're not social workers. They're not meant to be sort of saviors of any sort, but they're meant to be there, as Sandra says, side by side as they navigate sort of the complexities of many things that they're going through. So they don't have a big health component right now. Sandra has a mental health component, but we've been talking to her both from CTSI and our Center for Health Equity that we would love and be privileged to work with her on the health side. And what I like about it is it's just very circumscribed that, I'm a scientist, that you can measure things over time. You can see if things are getting better. You can see if things are getting worse. And also, they're not just numbers. They're real people that you can actually get to know, because 1,200 people is a number that's manageable. Our president here last week, President Kaler, was actually speaking to the NAS group about the university's commitment, and it turns out the university is very involved through social work, the law school, and others. And now, of course, the Health Sciences Center is getting interested in working in the Northside Achievement Zone. So the challenges for our center are a couple-fold as I think about sort of lessons learned over the last 4 years. We have 1 more year left on the grant. One is we would love to engage philanthropy more. We have zero philanthropy so far, so you can only go up, not down. The second is our community advisory board. So I'll just say a word or two about that. So we had a community advisory board for the last 4 years, and I'm sure we could spend an hour talking about this. We compensated them quite well, actually, probably more than other community advisory boards at medical centers. And when I talk to people and I tell them what we compensate, they said, "Whoa, that's interesting." The attendance at our community advisory board meetings was very poor, and it wasn't an engaged meeting. And I have to say, it's ultimately, partly, maybe mostly our fault. So we sort of have dissolved our community advisory board, and are going to reconstitute it this coming month. And we're going to do it on the backs of the center with that larger entity called the Clinical and Translational Sciences Institute. I was less involved in our community advisory board. Someone else was leading it. I don't want to say it was their thing. It's ultimately my problem. But if anyone has any thoughts on community advisory board during Q&A, I would love to hear your thoughts on it. In fact, another senior leader in the field says, "Oh, we don't compensate our community advisory board members at all. They don't seem to ask for it, and we don't think that's why they should be there." I disagree with that, but I want to know what's the way to really get people invested and engaged so that they can be a part of what we're trying to do. The other thing is, we didn't convene our external advisory board in years 1, 2, or 3. We finally got them in on year 4, and it was fantastic. Those are the names that I showed you in the beginning, really senior people in the field. And they gave us tremendous feedback on things that they thought we were doing right and things that we were maybe not doing right. One general comment that came along was that we didn't have a theme, which I actually completely agree with. They were impressed that we had a lot of programs. We were just rolling out programs after programs. Community dialogue series, community research institute, undergrad program, and so on and so forth. And that we didn't have a general theme that was bringing this all together. And I think that's in part probably my fault, but I think the idea was that we wanted to really establish and make a change at a university that just was doing very little in this area. So I think it has its pros and it has its cons. We have an internal advisory board, which would include people from other entities on campus that I have never convened. You can see it's not a lot of convening going on at these boards. And then we had an annual day-long health equity symposium like you had today. And we've done it once, and we've debated if we're going to do it again. And if you speak to anyone like Aaron and others who put these together, it's a lot of work. I was thrilled to see the attendance, which of course as the day goes on tends to thin out a bit. But the attendance here has been fantastic. We just have to think if that's something we want to do. If we do it, we'll probably do it in partnership with other entities in the city as well as other entities on campus. Our future plans are to really actually create a dynamic community advisory board that feels like this is something they want to do. We're going to further integrate this center into this Clinical and Translational Sciences Institute and leverage their big dollars into our infrastructure. We have to renew our center grant, which is critically important because no money, no center. And then unless we get huge philanthropy, and Mayor Bloomberg did not go to University of Minnesota. Bill Gates did not go to University of Minnesota. And a lot of you went to Minnesota, so if you want to be part of that philanthropic movement, we're ready. The other thing is that we really want to continue to generate new leaders at all levels in academia and community. And when I mean academia, I mean undergrads, grad students, and all the way up to faculty. And then in the community, that would include high schoolers as well. So we have to thank our funders. It's Men in Black 1. And then thanks to all of you for the invite to come back to Atlanta. Thank you very much. Comments, yeah. Community Advisory Board.
Well, I'll fill the space here. It's an extraordinary set of accomplishments that you're able to present. But it reminded me a little bit of another place in Minnesota Lake Wobegon, where all the kids are above average. So could you tell us a little bit more about what the problems you've had? Because engaging community is a critical part of this, and you have a small and what appears to be compact group that appear to be at the lower end of the socioeconomic scale, but there are differences within that group, and then there are differences within the group in the majority group too. And how do you access that, and what kinds of problems have you had that maybe could help us out too?
Sure. Did you say Asian group, by the way? I thought about 3 sentences back you said in the something group. Did you say Asian or?
I think I was hoping to say majority group.
Okay, maybe.
To use the phrase that Dr. Satcher used.
Sure. Well, let me answer it in a couple of ways, and then if you need a follow-up question, do so. So you want the dirty laundry, yeah? That I have no trouble hearing it. So I don't do it in the slides because you guys might keep the slides and put it on the web or God knows what kind of thing. So I guess there are a couple of problems. I mean, there are problems, sure. So here's one problem that, of course, people at Georgia State would never have because you guys are all wonderful people. So there's even internal politics. So when I moved to Minnesota in 2005, the dean and I recruited one of my former mentees. I won't say names, from Kansas, where I was before. He was literally my mentee. He was a young assistant professor to lead a new program in Health Disparities Research. He was doing that while I was sort of in the senior vice president's office, establishing that other job I had called the Office of Clinical Research. After I stopped doing that, I came back to my nicotine tobacco research, and this RFA came out from NIMHD in 2008, I guess. Yeah, 8. It was during the summer, I remember. And the dean of the med school asked me to lead it. And the person who I recruited to head up that program wanted to lead it. Long story short, that began some issues. We established the center, and this person's involved in the center, but it's been problematic. And I mean, this is just, you didn't really ask that question, but I'm just going to give you a couple of issues that one deals with. So that's been one thing. And in a place like University of Minnesota, which is a very research-intensive organization, you heard Mark Becker talk about your research dollars here. We have $700 million a year in research funding. It's massive. And so you can imagine, in obesity, we have 3 major obesity research groups. In diabetes, we have 2 big diabetes groups that sort of fight for each other. And, and there's reason why people do this. Schultze, the CEO of Best Buy, ended up giving $50 million as a donation to one of the 2 diabetes groups. They both didn't get it. It turns out the biomedical one, the islet cell transplant unit, the very sort of clinical one, got the $50 million. So I think there's been that thing. And, we'll work through that. One thing we're doing is we're trying to generate new young people, assistant professors who can lead cores and lead things, and getting postdocs who become assistant professors. So we're not trying to concentrate all the power in me and a couple other people, but to sort of spread it so that we have more people doing things. So that's one thing that we faced with, and that wasn't minor. A second problem we had was we had a hiring pause. I don't know if you remember those days in 2008-9. The states were having disaster with money. So we had a hiring pause, and I had to post a position for the administrative director of the center. They really run the place. I'm sort of like out of town, like here, while people there really do the work. And that took 8 weeks to clear and 8 weeks to hire, and this, that, the other. Anyway, it's sort of a funny story. I hired someone. This is back in the first year. They joined. They had an interesting background. They had a PhD in divinity or something, or theology, and a master's in psychology. The person, after a couple of weeks, had to go back to Africa because there was a family illness. He went for a week, and he was supposed to be back, and we hadn't heard from him. And so I emailed him. I didn't know how else to reach him, so I emailed him, hoping he would answer his email. And I said, we were wondering when you're coming back. And he sort of wrote back to me and said, there are issues here that I have to take care of. I'm not sure. Imagine getting an email like that. The guy worked for me, and I didn't know when he was going to come back. And long story short, it appeared he was not coming back. He was going to stay in Liberia, which is where he was. He had some things. So we actually said, you're no longer working here. Just send us your keys, I guess, from Liberia to your office and give us your phone back or something. But so that really, I'm joking, but it was really quite terrible because we had to then rehire. We lost a year. The bottom line is we wasted our first year. We had a massive carry forward after the first year. So that was sort of depressing. And so that's why I sort of went berserk just launching programs. Now in the community, which is what your question was more about. We were our center got funded on the tails of this sort of, the university was thinking of renovating that building in North Minneapolis. And there were these town forums and so on and so forth. And the president wouldn't go to these things, the president of the university, but he would send this guy named Robert Jones, who now, by the way, is president at University of Albany in New York, starting this January. So Robert was the senior vice president at the university. He was African American, which I think, for the face of the community is something they could connect with better. But Robert would often go to these events, and I'm not exaggerating. People would come up to the microphone, like Rodney's just about to do, and say, "All you do is you use us." I mean, angrily, very angry at the mic. The whole thing was just very uncomfortable. And it just took almost 2 years for that to, I wouldn't say it's perfect, but just to cool down. And the university's investment in the community and many other things that we're doing have really begun to slowly pay off. But it doesn't turn right away. The mistrust, I'm not trying to be too dramatic. I mean, it's not Tuskegee, but the mistrust of sort of the university. And the other thing the university did, which was interesting, is the University of Minnesota had something called, it's something like actually doesn't Emory have a smaller liberal arts college that has another name? Oxford, right? Yeah. So it's equivalent of that. I don't know. I think that's what Oxford's about. But Minnesota it was a college for people who didn't necessarily go right into the regular College of Liberal Arts. The university president shut that down. And he was called a racist for that and so on and so forth, because that college more proportionately had students of color. And I think its standards for admission were slightly different. And so that didn't help. So there's sort of been a lot of this tension that's been going on. There's also tension not separate from the university amongst groups themselves. There was a very bad food fight, believe it or not. The police were called in South Minneapolis at a school where it's quite diverse. There's a strong African American student body. This is high school, and a strong African population. I think it might have, I don't know which country, but sort of black African population. And it led into sort of a bad food fight situation, and the police got called. It's really quite sad, actually, that this happened. And there's a tension between African Americans who grew up and were born in this country and immigrant black Africans. You might see that in Atlanta. I don't see nodding heads one way or the other, but it's very real in Minneapolis. We have a rapidly growing Latino population that is not bilingual, that is Spanish-speaking only. And I forgot to mention, actually, this week, it was earlier this week, we have a very large Hispanic-serving nonprofit organization called CLUES. They have 100 employees. It's huge. It's in St. Paul. And the CEO and president came over to meet with me and our center just this week to talk about ways we could partner together. There seems to be less mistrust, double negative, less mistrust in the Latino population and the university. But I just think it's just taking time. It's moving slow. The trick is anytime a request of applications comes out from NIH, we don't rush to it and then try to jam it down the community's throat because we need a community partner. Sometimes it's not ready as much as it hurts me to let it go. We don't respond to that RFA knowing that the time is not ripe yet to do that. Does that answer some of the questions? Yeah.
Chaz, thanks for your presentation. I guess I have some questions, or I'll just ask you one about sort of all of us in the room. There's a lot of expertise and interest in here and no shortage of opportunities around health disparities and doing that work. You all have a center, we have a center. How do we leverage all the expertise and capacity in the room? Emory has an initiative, we have an initiative, Morehouse is doing things. This is all positive. Yeah. But how do we coalesce? How do we build synergy across all of the efforts and institutions, organizations that are actively working on these issues? I mean, I think, we have identified a few neighborhoods and programs and collaborations that we're doing, but there's more work to do. And how do we kind of bring it together, if you will?
So it's a fair question and something I've definitely thought about. before on this visit. So Atlanta's a big city. There's no shortage of work or problems. And I know even these beautiful institutions, there's tension between the different institutions. I was on faculty at Emory. I know your institution because of Mark and Becker and Michael Erickson. I know the dean of the med school very well at Morehouse. Valerie Montgomery Rice was my very close colleague in Kansas, small world. And you have Georgia Tech. But I think the city's huge. Each university, there's enough there going on that there should be a sense of light competition amongst each other, but really trying to work together. And actually, that CTSA grant that I was talking about, the big one we have, Emory has one, but it was pretty well known in the field nationally that Emory wasn't going to get one unless they partnered with Morehouse. And Morehouse probably couldn't get one alone unless they partnered with Emory. They partnered, and they got it on the first shot. And it's been great. They got renewed last year. Yeah, I think they got renewed last year. And so they're on their second wave of a 5-year cycle. So that was sort of a completely win-win situation. Emory, as you know, has a big sort of biomedical engineering thing or nanotechnology thing with Georgia Tech, and so on and so forth. So I think, and Rich Rothman used to be at Emory, right, in family medicine, where our offices were, I think, a block away from each other. So I think utilizing the connections that you have, and used to be at Emory working with my friend Ken Resnikow, but take advantage of all that people currency power that you have and begin to show everyone it's a win-win situation. If we do these things together, besides the good reasons of social justice and the fact that people will benefit from it, the selfish reasons, if you will, that if we go in together, we're stronger. More and more people are now doing health disparities and minority health research, A, because it's fashionable, and B, I have to put it bluntly, there's so much more money there. And so everyone and their mother around the country, Drexel, Hahnemann, every university. And so when we got ours, and maybe you got yours, I'd have to say it was easier. It's going to be harder on this next cycle, let alone sequestration and budget cuts. I'm talking budget neutral. It's going to be harder. So how do you set yourself apart? And Emory doesn't have one of these grants. I know that well. I don't think Morehouse has one of these either. Do they? Who's the PI? It's a P60? He has a P6? He's got special things. Thatcher. No, I didn't want to take away from Thatcher. No. They have money that you and I can't dream of. No. I just didn't know if he had this measly little grant. That's all. No. They're doing fine. They have a long lineage of former secretaries of Health and Human Services and Surgeon Generals, as you know. So, but I think again, win-win situation. Now, the other thing is I took a slide out, but you asked questions that you really should leverage your own institution. You obviously don't have a med school. You have this Institute for Public Health. But if we agree this whole social determinants of health stuff, and Anna's talk was, I thought, fantastic, is that you really have to think, what do you need to, and then someone asked a question about transportation, is that you have to think about really, what are we talking about here? It's really sort of a multitude of things. It's transportation, it's socioeconomic status, it's architecture, it's psychology, it's experimental psychology, it's sociology, it's anthropology, medical anthropology, social anthropology, cultural anthropology, it's physicians, it's epidemiologists, it's statisticians, it's evaluation scientists. It's really, and I'm not just saying this just because it's vogue to say these things, but bringing that brain power together and trying. The challenge, of course, is that people are busy, people are what's in it for me, and that kind of thing. If you do it and then you get this funded, more things come down the road. Like I know you guys are applying for, as we are, for this MHERT. I forgot what it stands for. MHERT. Minority Health International Research Training. There you go. Which takes undergrads from underrepresented minorities, underrepresented populations, which by the way can be white, first generation college, and places them. It's sort of a quirky RFA. I sit on council, so I knew it was coming out. But it's a quirky RFA because it takes these students and sends them abroad. Which is often maybe the other way around. But it sends them abroad. Well, Georgia State. You just heard Mark Becker talk about I don't know if it's true or not, but he said it. But you're the most diverse university in the country. It sounded like you're diverse in the sense that you're not officially, you're not Hispanic serving university, and you're not historically black college university. You're just a university that happens to be, in fact, I agree, very diverse. So grants like MHERT, if you put together a tight application, I'd fund you. I'm on council. I will approve you, but I have it's done by peer review. We just rubber stamp it, But I'll look for it your application in 6 to 8 months. But I hope you get funded. But you should get funded. You apply for that. There's a little bit of salary support. Then you get a T32 grant, which is a training grant. Then you fund your, not your MPH, your PhD students mostly. You can do MPH as well. You get that. You get an R01 grant. There's a special program. It used to be called Minority Supplement Awards, but post-Supreme Court case, it's now called Supplements for Diversity or something. And basically, I can fund a faculty member at 50% salary support by writing 3 or 4 pages. It doesn't go for peer review. It's reviewed in-house at the institute, NIMHD, NCI, and that kind of thing. I'm getting my head cut off. So there's really ample money. I say go for it. And I say go for it in a big way and work together to sort of keep applying for these things. Get your grants peer reviewed beforehand, like that little trick I said. Get time to incorporate the feedback and just submit them and make noise. You're advertising for faculty. Make noise nationally. Go to these meetings and get very present and visible. I think it's very exciting what's going on there. I was listening to Mark Becker when after he was walking out, I went up to him, I said, damn, I should have taken that job and worked for you years ago. I mean, I'm sure he's got his issues that are wrong. I don't know what they are, but he's very inspiring. And I think to have a leader like that, I think it bodes well for Georgia State. Thank you very much for your time.